Narrow, complex tachycardias. A narrow QRS complex means it is less than 120 milliseconds. This shows that the ventricles are activated rapidly through the normal conduction system. Since the tachycardia originates within or above the AV node, we call it a supraventricular arrhythmia. Let's go through the different types one by one. The first one is atrial fibrillation. Here the rhythm is described as irregularly irregular. That means there is no repeating pattern, and both the rate and rhythm are irregular. On ECG, you will notice no discrete P waves. Instead, the baseline looks irregular, and the RR intervals are all different. The arrhythmogenic activity usually starts from automatic foci near the pulmonary vein ostia in the left atrium. Risk factors include hypertension, coronary artery disease, advanced age, and atrial dilation. One of the most important complications is that atrial fibrillation can lead to thromboembolic events, especially stroke, because of left atrial blood stasis. The most common site for thrombus formation is the left atrial appendage. For management, remember ABCD. A for anticoagulation if needed, and for rate control use beta blockers, C calcium channel blockers, and D digoxin. Rhythm control can be achieved with cardioversion. Next is multifocal atrial tachycardia. This is also an irregularly irregular rhythm, but the key feature is the presence of at least 3 distinct P-wave morphologies. That means on the ECG you will see 3 or more differently shaped P-waves because the activity is coming from multiple ectopic foci in the atria. It is often associated with underlying conditions like COPD, pneumonia, or heart failure. Now let's talk about atrial flutter. In this condition, the atria depolarize in a rapid, identical, and consecutive fashion. On ECG, it gives the characteristic sawtooth appearance of P waves. The activity usually comes from a reentry circuit around the tricuspid annulus. Management is similar to atrial fibrillation, rate control, rhythm control, anticoagulation if indicated, and in some cases, catheter ablation of the region between the tricuspid annulus and the inferior vena cava can be used. Sometimes you may see a 4:1 conduction pattern on the ECG, where 4 atrial beats correspond to 1 ventricular beat. The next one is paroxysmal supraventricular tachycardia, or PSVT. This is most often due to a reentrant circuit between the atrium and ventricle, commonly located within the AV node. Clinically, it presents with sudden onset palpitations, lightheadedness, and sweating. To terminate the episode, we aim to slow AV nodal conduction. This can be done with vagal maneuvers like carotid massage or with adenosine. The definitive treatment is catheter ablation. Finally, we come to Wolff-Parkinson-White syndrome, which is the most common type of ventricular preexcitation syndrome. Here there is an abnormal, fast accessory pathway called the bundle of Kent, which connects the atria and the ventricles, bypassing the AV node. Since the AV node normally slows conduction, bypassing it causes the ventricles to partially depolarize earlier than normal. On ECG, the key features are a shortened PR interval, a widened QRS complex, and a characteristic delta wave. That's the slurred upstroke of the QRS complex. This condition can lead to a reentry circuit, which then causes supraventricular tachycardia. Treatment involves drugs like procainamide or ibutylide. Importantly, you must avoid AV nodal blocking drugs, such as adenosine, calcium channel blockers, or beta blockers, because they can worsen the conduction through the accessory pathway.